All right, it is the top of the hour, so we will get started. I'd like to welcome everybody to join us for our first virtual UCSF Geriatrics Grand Rounds. I am Louise Walter. I am the chief of the UCSF Division of Geriatrics, and I'm very pleased to be moderating this Grand Round session. As a few quick reminders as we get started, the meeting is being recorded, and as an audience member, your microphones are muted. So if you want to ask a question, please put your question in the Q&A since we have disabled the chat function. And then the plan is to answer all questions at the end of the presentation. Today's Grand Rounds is titled COVID-19 and Older Adults, What Have We Learned and How Can We Do Better? So this Grand Rounds is going to focus on 3 areas where the US has really fallen short in how we've been able to help our older population, which has really been disproportionately affected by the COVID-19 pandemic. I think the COVID-19 pandemic has shined a light on these gaps. And these gaps are loneliness and social isolation, long-term care, and goal-concordant care. So for this Grand Rounds, geriatrics faculty who are experts in these areas are going to be discussing each gap area. And we're going to have 2 presenters for each area, and they'll each focus on a few key points about what has been learned and how we can do better in these areas going forward to really improve the lives of older people. So now I'm going to introduce our 6 speakers. Next slide. So Dr. Carla Perissinotto is an associate professor and associate chief of the UCSF Geriatric Clinical Programs. She leads our clinical programs at UCSF Health and is internationally known for her research on loneliness and social isolation. Dr. Ashwin Kotwal is an assistant professor and UCSF Pepper Center scholar. He's our first person to complete our 2-year integrated clinical fellowship in geriatrics and palliative care, and his research focuses on improving social connections. Dr. Louise Aronson is a professor and author of the New York Times bestseller, Elderhood, Redefining Aging, Transforming Medicine, Reimagining Life, which was a Pulitzer Prize finalist this year. She's part of the San Francisco Department of Public Health COVID-19 response, and we'll talk about long-term care. Dr. Anna Chodos is an assistant professor and leader in ambulatory geriatrics at Zuckerberg San Francisco General Hospital. She's also a leader in the UCSF Geriatrics Workforce Enhancement Program, and again, part of the San Francisco Department of Public Health COVID-19 response. And she'll talk about residential care facilities for the elderly. Dr. Rebecca Sudore is a professor and director of the Vulnerable Populations for Aging Research Core of our Pepper Center. And she's internationally known for her research to improve advanced care planning and medical decision-making, and has designed, tested, and disseminated many patient-centered tools, including the advanced care planning website called Prepare. And then finally, Eric Widera is a professor, director of the Hospice and Palliative Care Service at the San Francisco VA, and director of our Geriatrics Fellowship Program. He's published about a novel virtual consultation model staffed by out-of-state palliative care specialist volunteers, and was one of the volunteers providing consults to patients at New York Presbyterian Hospital during the COVID-19 pandemic, facilitating goal-concordant care. So we've got a stellar group of panelists, and without further ado, I'm going to turn it over to Carla.
Great, thank you, Louise. It's great to be here with everyone this afternoon. I am going to be introducing the topic of loneliness and social isolation among older adults during the COVID-19. Next slide. So it's no surprising to all of us that we have been in a shelter in place. There's some variation across the United States, but our shelter in place here in San Francisco started in March 16th. It's expected to be until the end of the month, but there's speculation about it increasing or progressing. What is important about the shelter-in-place order is that this highlighted something that we already knew what was going on, which was that people who are experiencing isolation, whether that's forced or voluntary, may have increased risk to their health. Next slide. Now, the challenge is that when the shelter-in-place order was started, we were not really aware of what this would mean for the well-being of our older adults. And so my colleague and I, Dr. Ashwin Kotwal, Julianne Holt-Lundstadt from the Brigham and Young University, and I had a question about how would the shelter-in-place affect the well-being of older adults and have older adults adapted. Next slide. What's important to know during all of this is that there's been many terms that have been used. We've seen the terms social distancing be discussed, but it's important to think about that really what we're doing is actually physical distancing, but the physical distancing may ultimately have an effect on social isolation and loneliness. Now, it's important to get these two terms correctly as we move forward and talk about the data that we're gathering and the research that we're conducting. Loneliness is really the subjective assessment that someone is the subjective feeling that someone has and that social relationships are lacking. So there's a discrepancy between desired and actual relationships. Social isolation is something that's objective in terms of a quantifiable number of relationships and types of relationships. So what we're seeing with these shelter in place is that the physical distancing is creating more social isolation and increasing the risk of loneliness. Next slide. Now, I'm going to turn it over to Dr. Ashwin Kotwal, who will talk a little bit about the details of the study. And again, what we'll highlight is that this is incredibly timely because just prior to the shelter in place, we had the National Academy of Sciences come out and indicate that there's an important role for healthcare systems to play in understanding loneliness and isolation in older adults. Thank you.
Thank you, Carla. So thinking about our study, we were interested in understanding the experience of loneliness and social isolation among older adults in San Francisco. So we began recruiting participants from 3 separate sites: this UCSF Geriatrics clinics, Covia Senior Life, and the Curry Senior Center, which is located in the Tenderloin neighborhood of San Francisco. We were really fortunate to have involvement through volunteer interviewers, including at our partner sites, as well as from UCSF medical students and pharmacy students to administer our surveys. We use phone surveys to really get at older adults who might not be able to participate in online or mail surveys. And we wanted to track people's trajectories over time through 2-week follow-up interviews, assessing psychological well-being, social connections, and key medical needs. And importantly, this is an ongoing study, so I'll be presenting some of our preliminary results. Next slide. So who did we interview? We had 141 respondents and 309 total interviews, including the follow-up surveys. Our participants were quite reflective of a geriatrics clinic. So the age on average was 75 years old. We had a wide range of racial and ethnicities. So white was 71%, and then a range of other ethnicities. And you can see on the right-hand side, a bar graph showing some of the other characteristics. 64% of individuals were female. About 2/3 of our sample lived alone. Nearly a quarter were married or partnered. A number of people reported low finances, self-reported depression or anxiety, and we were able to capture a number of people with functional impairment, whether it was hearing or vision impairment, or impairment in activities of daily living, like bathing, shopping difficulty, or difficulty accessing transportation. Next slide. So next, I'll discuss loneliness during COVID-19 shelter-in-place orders. Next slide. So one of our key findings was that many older adults have experienced worsened loneliness. We assessed loneliness in 2 ways. The first was through a standardized loneliness scale, where we found that about 31% of our sample reported frequent feelings of loneliness. We also asked individuals whether their feelings of loneliness changed due to COVID-19, so more of a direct question. And what we found was that about 43% of individuals reported that their feelings had worsened because of the pandemic and the current public health restrictions. We were interested as well to understand whether there were predictors of loneliness that might inform who might be most at risk of this emotional experience. And we found, using regression models that controlled for other clinical characteristics, that depression, anxiety, and cancer were medical conditions which really predicted a higher risk of loneliness, as were functional impairments like bathing, shopping, or difficulty accessing transportation. Next slide. We were also interested in understanding the trajectory of loneliness over time. And so in this figure, you can see on the y-axis is the loneliness score, with higher scores representing worsening loneliness. And on the x-axis, the days since shelter in place took effect. And you can see that there's an incredible diversity of individual experiences. And from this, we were able to understand three general patterns. Next slide. The first pattern was that individuals whose loneliness worsened over time. And so on the right-hand side, you can see in general, loneliness scores increased, or there were sustained worsenings of that experience. And we have quotes from our participants that were illustrative of this experience. So one participant, for example, reported, "This has been the hardest thing I've had to do in my entire life. The isolation has made my mental and physical health worse." Next slide. A second pattern was individuals who initially had high loneliness, but that improved over time, suggesting that people were able to adapt or cope as the shelter in place progressed. Here's one quote from an individual. "I do reach out to people when I feel lonely. I'm trying not to make a big deal out of it because I know it is temporary. I'm feeling better in the last 2 weeks because I'm more informed and know what is going on due to the virus." Next slide. And then the third pattern was people who were not very affected at all. And you can see on the graph, kind of hovering around 0 or pretty minimal loneliness. And a quote was, "I've had more support during these times than before. I've learned more during this time about technology, had a chance to read more, and even help other people through technology." Next slide. So what was the key lesson learned here? Many older adults are experiencing worsened loneliness, but it's not a universal feature. So key factors to keep in mind are mental health. Do people experience functional impairment? And what's their ability to cope? So what can we do better? Clinically, I think it's important to ask about loneliness. It seems obvious that many people might be experiencing this, but it's a really challenging topic to discuss. And many people we're finding are appreciative of being able to talk it through. We need to learn about how people are adjusting and be aware of these clinical risk factors. From a research standpoint, we need more funding and research on interventions that do not rely on in-person interaction to improve loneliness. Next slide. Next, I'll discuss social isolation and obtaining help. Next slide. So we examined how people are interacting during this time. And you can see on the graph 4 different types of interaction on the x-axis: in-person, telephone, video, and internet, and the frequency of these types of interactions. We found that telephone communication was the most common form of interaction, which was unsurprising to us. But for video interactions, we found that the vast majority of people, nearly 80%, had minimal or no video interactions, which was sustained during the pandemic time, and 43% had minimal internet use. Next slide. Social isolation feeds into difficulty obtaining help, and we identified several areas of need. Many people reported that they have not been able to do clinical telephone or video visits, but were still interested, about 20%. The vast majority of our sample reported difficulty obtaining medications, so nearly 80% of individuals. 20% reported food insecurity, and many people continue to have difficulty finding assistance with activities of daily living or instrumental activities of daily living, including bathing, preparing meals, groceries, managing their medications, and transportation. Next slide. So the key lesson learned here: the majority of adults in our sample had minimal use of video or internet, and we identified several concerning unmet needs among older adults in San Francisco. So there are a number of things I think we can do better here, but for isolation, facilitating the use of technology among older adults, I think many people are interested but not able to access these technologies. And we also need to think about strategies that do not solely rely on video or internet technologies. And in terms of addressing unmet needs, thinking about critical needs like food insecurity, obtaining medications, and functional support, these continue to be challenges. And strategies to safely provide support with activities of daily living and instrumental activities of daily living. Next slide. And we just really like to thank our study participants, a number of our research staff, and a special shout out to UCSF medical and pharmacy student volunteers who have been so generous with their time. Thank you.
Okay, so it looks like I'm up. Anna Chodos and I are going to be talking about COVID in long-term care, to focus on challenges, lessons, and opportunities. So next slide, please. Our first few are slides that are just going to run us through a little history of how we got here. So when COVID arrived in the United States, we already knew from pretty significant countries like China and Italy that it was much more lethal in older adults, particularly in those over age 80, but with risk beginning to rise in the 50s and going steeply up starting in the 70s. And then we got our first cases in the United States in a nursing home. This really showed a few things, that the high-risk population in congregate settings would be vulnerable, and that we didn't yet know how it would get in, which meant prevention would be critical. Next slide. Despite that very suggestive evidence, we didn't necessarily focus on skilled nursing in the United States, and pretty early on we saw the same pattern of older people, surprise, surprise, dying, more so in the United States. But this probably represents a gross underestimate, as we have seen with excess deaths. There were lots of people who never got tests. There was very little transparency. The physician journalist Elizabeth Rosenthal has a piece in both the Times and Kaiser Health News today about her mother, who was 96 and died of COVID, and she admits that wasn't the worst thing to happen to her mother, but that her mother isn't counted. And I know I've seen this, and we've all heard about it, the people who couldn't get tested but had telltale symptoms. And the people who were so ancient and frail that their death wasn't much of a surprise, so it seemed, why count them? Well, if you don't count them, you don't get the resources you need. So we expect that these patterns actually show lots of missed deaths. All right, next slide. We move to April. Now, for months, the San Francisco Department of Public Health has been reporting how many cases and how many deaths in the chart that you see here. You can click on cases or deaths. I chose deaths. Because for most of the time through April, all the deaths but one were in people over age 60. But that's not the only reason I show this slide. I also show it because over age 60, it's really not enough information. And it suggests a certain bias, a lumping of older adults into a single category that probably has informed our response and may be responsible for some of the excess social isolation we just heard about. So imagine if the population affected were kids, but it was really affecting toddlers a ton more than teens, or vice versa. Or if this were affecting adults and it was really affecting 20-year-olds, but not so much 50-year-olds, or vice versa. This would probably be represented in the data, but we don't see it here. Next slide, please. Then we come to May, the month we're still in, and the San Francisco Chronicle has had a bunch of exposés about nursing homes in San Francisco and in California. And they're talking about how slow testing is to get there. Another thing that's been slow has been PPE, because we prioritized hospitals. And if you look at the numbers for UCSF, the most patients that we've ever had at our medical center at any one time were 21. That happened on 4 days in sort of mid-April and early May. We've had many more cases at various skilled nursing and residential care facilities. And although PPE is scarce everywhere, it has been sent more to hospitals, even in cities, counties, and states where more of the deaths were in skilled nursing facility. In some cities, in some states, the percentage of deaths is 70% or 80%. We now do see the breakdown by age, and it's interesting. It's not exactly what you'd think, and that probably represents comorbid conditions, but still the people over age 80 are at highest risk. And that that's the point where, as we're teaching geriatrics, I'm sure other people like to do this, but ask people, what percentage of Americans live in nursing homes? And most people will say 50, 70, 80, and really it's 3 or 4%. But we know it goes up higher in the people over age 80. So when we see these large numbers of people over age 80, we're really talking about skilled nursing. Next slide, please. Okay, so this is a daily email that we get from the San Francisco Department of Public Health, and this is a fairly recent one. And you can see that one of the big areas for cases, this is the wrong slide, or it's not, anyway, it's the right slide. I was meant to black things out, but the most of the cases are still in skilled nursing and residential care. That's where we're seeing most disease, although clearly other populations are at high risk. You'll also see that in May, they released the Skilled Nursing Facility Toolkit, and that we're still awaiting long-term care facility guidance. This is particularly interesting because the California Department of Public Health, when this first happened, issued guidance and said, we've been preparing for this for 10 years. But now we're many months in, and it was clear from February that skilled nursing would be adversely affected. But we're still developing the tools and the strategies for this and pulling them together as people remain very impacted by this in skilled nursing facilities. Next slide. So what have we learned? Well, I think I learned a lot of things. Some of the best things I learned is that incredible numbers of people, hundreds of people have volunteered or been repurposed through the Department of Public Health and have worked tirelessly to make a difference across incredibly diverse and complex communities, and really with very few systems in place to begin with. But the second thing is that, as in so many places, there wasn't much expertise in elder care in the Department of Public Health. The good news is they were really happy to have help, very welcoming, offered FTE for those of us who are willing to work, and are really very collaborative. The organization and communication has been a challenge, and I think it would be helpful for all of us to consider how we might inform this going forward. So we've known for skilled nursing, it's a problem since the start of the pandemic, and yet certain fundamentals are only now being developed. And when you have lots of different branches, figuring out how to communicate among them is critical. I feel like these are lessons that could apply in a crisis, but could apply equally to our everyday lives. There is a real focus on disease, and I bring this up because, not because it's wrong, especially early in a pandemic, but what we're seeing now in skilled nursing facilities, and certainly in all the ones that don't have cases, are what Carla and Ashwin just talked about: the deconditioning, the depression, the missed health needs really showing up and adversely affecting people. So it's possible that our reaction to this first public health crisis is causing a second one, especially among frail elders. And the focus has been very much disease, not health. There is also some tension between city and state departments of public health. They do work together, but figuring out which one's in charge of different things can be difficult, and sometimes the messages aren't quite as in sync as you'd want. Next slide, please. So what we can do differently. We could be a part of the Department of Public Health response immediately. I think I sort of thought, well, they have all these people, they've got this. And I hesitated, and maybe a bunch of you did too. And I think it never hurts to offer. And one of the things I learned is that most people are really happy to have people who know about something help. And I would offer that sooner. It's also true that, like all of us, people who are doing this don't always know what they don't know. And many of the people put in charge of skilled nursing facilities are specialists in tuberculosis or transportation or refugees or a variety of other things. So the more we are part of this process, the more our expertise can inform it. I also think we should do more to develop relationships with local SNFs. Now, this is tough in a world where 70% of SNFs are for profit, maybe 80%. So they're a little reluctant, and they're big corporations. And we have some relationships, but even if it was just for training, for consultation, something like that. I mean, if we are the people for vulnerable elders, then I think they could use more of our help. We call them healthcare facilities, but they're not really part of our health systems. And that's something that we might want to think about from a policy perspective. On a positive side, the crisis led to contracts with certain facilities and with the ability to help through the Department of Public Health. And so maybe we shouldn't have to have a crisis to be able to make a difference in these places. And lastly, division preparedness. So how can we who are in geriatrics or who are part of the larger health system make a difference? I think having crisis teams and mobilizing those, or at least knowing what the teams would be right at the start, would make a difference. And we were pretty quick on that, but I think we weren't as clear what to do. And I hope some of the lessons we learned will be how to collaborate with others. A lot of the skilled nursing facilities could have really benefited from help with the larger perspective. They were getting really good guidance on COVID and disease prevention, and they weren't getting as much guidance on how do we help everybody else be healthy? When do we actually contact the health system for people who are sick with all the things that people in skilled nursing are routinely sick for? And how do we keep track of deaths that were probably COVID, but we never had tests for them? And then lastly, I would just say we should all think about advocacy. Next slide, please. The data on SNFs remains incomplete and inaccurate, as the Chronicle showed. Reports of numbers are generally daily, they're not cumulative. So for people who don't understand statistics, it's going to grossly underrepresent what's actually happened. Facilities also, because they're for profit and don't want to be dinged for cases, don't count people sent to the hospital. I heard on a call that people in places in Florida don't count people with out-of-state driver's licenses. There is no hazard pay given to the staff in these facilities. So already they get paid less than hospital workers. Now they're not given PPE, and then they're not given hazard pay. This is really saying you don't care. We don't care about you as human beings. And that's why taking care of skilled nursing facilities is equally about taking care of the staff and advocating for their payment, proper payment, training, and well-being care over time. We should still be advocating for PPE for SNFs. Basically, this is like so much that happens in healthcare. Shouldn't resources go proportional to need? It's kind of like our geriatrics argument as shouldn't teaching about various diseases be proportional to the degree to which they are represented in our patients? And then we should have increased staffing, but actually if you're for profit, you lose money with more staff. So the opposite has happened. As Charlene Harrington, our one of our treasurers at UCSF, has said, we know some SNFs are trying to hide that they have the virus. They're doing this because they're businesses and they don't want anyone to know they have it. So I think academic medicine generally and public health should both be a bigger part of skilled nursing facilities. There's really good data to show that outcomes are better when we're a part of it. And if this crisis has taught us anything, it might be that we need to step up in this regard. And now I will hand it over to Anna.
Thanks, Louise. And hello, everyone. It's a pleasure to have a few minutes to talk to you and add a little bit about the work that we've been doing to support the DPH, specifically as well with residential care facilities for the elderly. So to complement the SNF work and to also support highly vulnerable adults in the community. So our role, and to be clear, it's myself, Louise, but also two other faculty, Edgar Pierluisi and Meredith Green. And we mostly are supporting a group that is working with those facilities that are licensed by the California Department of Social Services. So unlike the SNFs that are licensed and regulated by the State Department of Public Health, these facilities are licensed by another group, and that's how they sort of all got lumped together in the DPH response, frankly. They do have a lot of similarities, but they also have a lot of differences. And that's made this work pretty interesting, I would say. So these are the places that a lot of us think of as assisted livings, or we call boarding cares, but formally have these titles of residential care facilities for the elderly, residential care facilities for the chronically ill, which serve adults with HIV and AIDS, and adult residential facilities. And total, there are over 100 that we're supporting. and in the various categories here that I've listed. So most of them are licensed as RCFEs, but they're so variable in terms of what the facilities are like, and then also trying to think about the residents and the people that they're supporting. So some of them, in fact, many of them have 2 residents only, and many have much more than that, though most are typically under 50, but several have hundreds, the biggest being one that has 400. And just, again, we really try to think about and learn as we're reaching out to these sites and supporting them, who's actually living there, who are they caring for. Next slide, please. So Louise already alluded to the fact that this is a huge response, and I just wanted to show this picture because this is actually what it looks like to go to the response and work with other people, with the obvious exception, with the obvious changes here that, and obviousness that this isn't a picture of our current response because people are way too close together and they're not wearing masks, which is what it looks like otherwise. But everybody has these colored vests, they have a role in the response. And it definitely took some time, I think, in trying to volunteer, help out, and get oriented, just trying to understand who was doing what and where. And particularly given that this was an entirely new function of the Department of Public Health and everybody's roles had changed, I think it speaks to just the challenges of figuring out how to support these sites, which obviously we want the residents there, we want the people working there to be the priority, but the people in the response working to support those people are also trying to figure things out pretty much on a daily basis. Next slide, please. But the way it's sort of organized is they think about it in terms of preventing any infections from getting into staff or residents, mitigating a single case or maybe 2 cases at a site, and then responding to an actual outbreak. And the spectrum of things that we're doing really actually tie into all of those functions, but they're sort of thinking about it differently and putting different resources, different numbers of people to support the site and the residents there, depending on where they are in this sort of prevention, mitigation, or outbreak phase. But the main functions and the main things we're working on is figuring out how to help them with infection control, helping support the residents around behavior management, especially with all of the socialization and lifestyle changes that have had to occur, helping them get the appropriate supplies, and then increasingly trying to figure out how to help support residents and staff around mental health issues that are coming up with prolonged shelter in place. Next slide, please. So as part of our work, we reached out to all the sites, we got responses, or were able to talk to 84 of them to understand their current challenges and how we could help in a targeted way. And we more or less did these calls over a month. And I just wanted to give you a flavor of some of the things we learned in talking to them. So we did want to know who they're serving, who lives in their RCFEs or adult residential facilities. And many have over 60% of their residents 75 and older. So of course, we're, especially those of us in geriatrics, are thinking, how similar are these residents to a nursing home population, and what are some of their vulnerabilities? Some of them had positive residents and staff, but not many. So 7% had a positive resident and 10% had a positive staff member. 4 of those sites were overlap. They had one of each at least. We asked them, because we wanted to know how, we sort of thought that sites might be higher risk if they were having trouble with shelter in place and folks keeping social distance and isolating. And at least 14, or about 17%, said that they were having difficulty, or that it just simply wasn't possible given the environmental constraints of their facility or the behaviors of the residents and their ability to manage isolating or mask wearing. We asked them how much PPE they had, in part because we could make requests on their behalf to get PPE. And over half said they did not have a 2-week supply of PPE, which was a little bit arbitrary in terms of why we were asking, but we wanted to make sure they had a decent supply in the case that someone did get symptoms or was found to be positive. And then 3/4 had already received some training about what coronavirus was. It was a little surprising that all of them hadn't, because theoretically the licensing group had reached out to all of them in an attempt to reach them and do training. And so, you know, unfortunately, some of them still hadn't been able to contact with the licensing facility to get training. All of them had received materials, though, of some sort. Next slide, please. And then I just wanted to highlight, once we really dug into each of these areas, some of the issues that we're seeing. And again, we were really trying to reinforce things around infection control for obvious reasons. And the facilities really pointed out that they, you know, had to create these new processes around checking symptoms twice a day in everyone, reinforcing all of the public health orders around masks, social distancing, not leaving the facility, frequent sanitization, and just that these were totally new and clear challenges, but many were, you know, certainly trying to meet that challenge as best they could. We attempt to review with them what they might do if someone tested positive. Could they isolate or not, as I already mentioned. And then we often get questions about who else might need to be tested if someone were positive and how they would go about that. So that's something we're often navigating with them. Next slide, please. We have learned from many sites that the consequences of shelter in place, referring back to the prior presentations with Carla and Ashwin, that the no visitor policy and not being able to leave the facility is taking a tremendous emotional toll on residents, to the extent that we've heard some pretty harrowing and heartbreaking stories about people's emotional health really suffering. And that for the staff, it becomes very challenging, as sometimes behaviors are really either demonstrating for the first time or getting harder to control. And so trying to support them. And in one case, one of us supported a site pretty closely in working with the staff on addressing a behavior in some residents and tracking that and reinforcing good practices around behavior management, specifically in this case in residents with dementia. We go over a lot the lack of PPE and specifically what they lack, and many of them did lack at least some PPE. Face masks were very hard to come by, gowns very hard to come by. And then actually some just had super basic questions about how to use some of the PPE, how they might sanitize it. And so that was really revealing to see that, as many of you know already that are listening, that many of these facilities don't have any healthcare workers or trained healthcare workers, and so don't have prior experience with personal protective equipment in any form. And then learning that a lot of the staffing were challenged. Many had reduced the number of staff to reduce the number coming in and out, and were increasing their hours, but that the staff were expressing a lot of anxiety and fear. In some cases, they were having shortages. Most of them had a plan around getting other staff or contracting with other agencies. And related to, I think, some of the news about other fields where actually unemployment is paying more. Some of the facilities disclosed that their staff were actually making more on unemployment, and that was not helping them come back in a setting of some anxiety and fear around managing the virus and the residents. Next slide, please. We get a lot of questions, and we talk a lot about if there's going to be a regular mass testing strategy. So the public health order in San Francisco came out that skilled nursing facilities had to be tested every 2 weeks, all resident and staff. And many of these sites, which advocate for themselves as having an equally vulnerable population, and I think many of us would feel similarly, that they should be candidates for regular testing. That has not been announced, and we are, hearing different things about strategy. And I think there are a lot of things that are going into the decision about if it's possible and on what time frame. But we answer a lot of questions about this and trying to think through what would make sense. And in the meantime, are there other resources for them to get testing if their staff want to get regular testing, or if for some reason they think somebody has been a contact or high risk. We have regular meetings with other agencies to support these sites. So again, the licensing group, the community care licensing department here in the state, as well as the ombuds, that really does a tremendous amount of advocacy and support for these sites. especially if there has been a case there. And now we're learning, if you could advance one more, what if sites don't want more support? So we're getting to the point where we're making calls and trying to reach out and go over things again and again, and some sites are declining that additional assistance and trying to identify what our role is to continue to support them and the health of the residents if sites are really feeling like they don't need more support at this time. Next slide, please. So I just wanted to echo as take homes, as I've done a little tour through some of our work that hopefully is interesting to you and brings up some food for thought about these sites compared to skilled nursing facilities. But in addition to everything that Louise said about all the things that we can do, especially locally here in San Francisco, if you happen to be here, in terms of reaching out to us just to help support the efforts, you know, across the city for these sites or just for older adults generally. But I think no matter where you are right now listening from, supporting these sites by, if you are clinically working there, helping to check in with the site, the administrators, how can you help? Sometimes they just need advice or have a question about infection control or something like that that you'd probably be very skilled in answering. And if you're local, you could certainly communicate that to us if you have a patient and stuff is coming up that you think we could help support with education or further phone calls. And then helping them figure out testing locally if there is some resource, because here in the city, the resources are growing every day, even if we have not yet figured out how to organize mass testing on site for all of these places. And then I really think the advocacy that we are doing on behalf of our patients that live in these facilities, or that families and friends are doing, especially when we get calls at senior sites. And I put our number here if you are local and want to give that to a site where you have a patient or family member. But I think the advocacy is really important and helps the people who live there to be visible, the issues that they're dealing with to be visible, and helps, of course, mobilize support during a time where everyone's attention is being drawn everywhere. So I will gladly hand it off to the other presenters, but thank you so much.
Great. Hi, it's Rebecca here. It's really great to be with everyone. I know that we want to save time at the end, so we have time for some discussion. So Eric and I will be brief in our comments, really talking about some of the lessons we've learned and also thinking about tangible and practical tools that clinicians can use to help support advanced care planning and goal-concordant care during this time. So just really quickly to talk about some of the clinical realities when we're thinking about COVID-19 and advanced care planning. So we know this is a serious illness that can affect both the young and the old. The median age is somewhere between 56 and 63 years. And as we know from Louise's talk that the morbidity and mortality disproportionately affects older people, I think what we've seen in advanced care planning is that even younger age groups are interested in engaging. We know in terms of the clinical realities that the clinical picture can worsen quickly. We know that families and surrogates have not been able to visit in the emergency room or the hospital, and that unfortunately older adults particularly are not bringing in their hearing aids, glasses, cell phone or cell phone chargers. And frontline providers have been desperate to know any information about that person, about their wishes, about their family contacts. So all of this is happening in the background, and we're also finding when we call our patients that patients are actually more open to have these discussions. So go to the next slide. When COVID started happening, our team started to be contacted by health systems and our collaborators really nationally because COVID cases were increasing rapidly. Health systems and organizations were overwhelmed, and they really wanted practical, easy to read, easy to use solutions for both patients and their clinicians. And knowing some of the work that we did in advanced care planning, they reached out to us. Next slide, please. So we worked with organizations both on the West Coast and the East Coast and the Conversation Project, and with patients in diverse communities to come up with the Be Prepared, Take Control campaign. And we heard from diverse communities that they wanted something very practical that would address their fears about what's the next step and what if something happens to me. And so we really focused on a hospital go bag and choosing a decision maker and sharing their wishes. If you go to the next slide. This information is on our prepareforyourcare.org website, and people can download for free this simple tool called Making a Medical Plan During COVID that helps older adults plan for their medications, making a list, keeping that with them, thinking about a hospital go bag and what would go in that. So hearing aids, glasses, dentures, phones, phone chargers, and if they have an advance directive, to include that as well. Some simple steps people can do to plan for their medical wishes and other things such as planning for their pets or planning for money and their bills. These are things that we heard were important to older adults. Next slide. Many of you know that we house the Prepare for Your Care website here at UCSF, which is a step-by-step, easy-to-use website for older adults. If you go to the next slide, we have seen, next slide. We've seen sort of a fivefold increase just in the last 4 months in Prepare use. Again, I think showing that advanced care planning is really in the consciousness of people in the community. If you go to the next slide. We've had a large uptick in use of our easy-to-read advanced directives, which are available in English and Spanish for all 50 states. And if you go to the next slide, people have been asking, well, what if I have COVID-specific wishes, and where do I put those? And just to alert people that there is open space on our easy-to-read advanced directives for people to put that information. If you go to the next slide, people are also showing our videos in our group medical visit toolkit in group medical visits through video chat and televisits. And the next slide. We also created these simple scripts for anyone, including physical therapists or CNAs or anyone, to pick up to be able to start advanced care planning conversations. Alex Smith and Brian Block and I published this just recently in JAGS, and again, this resource is available for free on the Prepare website. Go to the next slide. And I think some of the things that we've learned and some of the key takeaways here are that health systems can use these free materials to message advanced care planning to a large group of people. So at UCSF, they sent out a very nice COVID letter to their all their ambulatory participants and included advanced care planning information in that. Here at UCSF and other places, people are using this COVID tip sheet in their after visit summaries and in the emergency room discharge information, and again, disseminating these simple scripts for all different types of clinicians to start these important conversations. And with that, I'll hand it over to Eric.
Great. This is Eric Widera. I will try to be even faster than Rebecca, then we have a little bit of time for questions. I'm briefly going to talk about education and programs that we created to meet the palliative care needs of individuals at risk for COVID or those who have it at the San Francisco VA. So when we were expecting a surge in COVID cases, the palliative care team at the San Francisco VA really sprung into action, something I'm really proud of about our team, including the work of physicians within the Division of Geriatrics, nurse practitioners, social workers, chaplains, other trainees who really came up with responses to meet palliative care needs. Next slide. For example, I just want to highlight one thing that Annie Palmer, the nurse practitioner in the CLC hospice unit, developed, which is just a just-in-time training for hospital-based nurses on how to manage end-of-life issues for veterans admitted to the hospital. Next slide. Shout out to Ashwin Kotwal, who also created this pocket guide along with one of our past fellows to help interns and residents deliver primary palliative care, which included both how to manage dyspnea, quick opioid tips, and kind of a goals of care conversation for individuals who are admitted to the hospital. Next slide. We also created advanced care planning guides that individuals could use outside of the hospital based on numerous expert sources like Rebecca was talking about, including Vital Talk. And we also taught this in curriculum to our outpatient providers, including trainees in our outpatient EdPAC clinic at the San Francisco VA. Noting that there were more barriers than just education delivering advanced care planning, our outpatient palliative care team also created a on-the-fly advanced care planning consultation in which a team, the outpatient palliative care team, would do a one-time consult for any veteran who needed documentation of advanced care planning. So any primary care provider could actually quickly put an advanced care planning consult And within 2 days, our outpatient team would be giving that veteran a call to talk about advanced care planning. Next slide. And the last thing I just want to mention is acknowledge some of the work that our physicians, both in the Division of Geriatrics and the Division of Palliative Care, did to help individuals in harder hit places. You know, really, it's been wonderful to see that the peak here in San Francisco, it didn't really peak. We had a kind of a slow wave that hit San Francisco, never really overwhelmed our hospital resources. Quite a different story in New York. So individuals, including Craig Blinderman, who is the picture in the middle, reached out to individuals here at UCSF, Dartmouth, and Stanford to create a volunteer palliative care, tele-palliative care program, where physicians here in San Francisco, Dartmouth, and Stanford would be doing virtual consultations for individuals in New York Presbyterian, Columbia. I just want to highlight, if you're interested in learning more about this too, our paper in JAGS, Journal of American Geriatrics Society, just got published, talking about how we approached these palliative care consultations, really spanning both state and institutional barriers to do that. Given that everything I just talked about or can talk about is in that paper, I'm just going to end there so we can have some time for questions.
All right. I've been looking at some of the questions in the Q&A, and so I'm going to now direct some questions to each of our panelists. So Ashwin, I'm going to direct the first question to you about, does hearing and vision impairment predict increased loneliness? Because you had mentioned about those issues, but does that affect loneliness?
That's a great question. I think we were expecting it to be associated with worsened loneliness. We certainly know that in prior literature, hearing impairment and vision impairment are associated with loneliness in general. But in our study, we did not find that it was associated with worsened loneliness attributed to the COVID-19 pandemic. So something we'll be looking into further.
Perfect. Great. Next question is to Louise about the idea of how do we better collaborate with our skilled nursing facilities, especially around engaging them around PPE, infection control, and training.
Well, I think, oftentimes we need formal contracts, but if you're willing to do something educationally and you're willing to do it for free, I think our experience through the GWEP and other things like that means that you don't need as much formal contracts, and people are usually pretty happy to see you and have your expertise supplement theirs. I think often there is somebody in charge of education or training, and if not, there is a director of nursing. And usually that person is well aware of needs and really happy to have help because she is underpaid for doing a pretty hard job compared to what she would get paid and what she would be doing elsewhere. So having a series of like small bites on key topics, because these are busy people and they really can't set them free. These places are strapped. So even if you taped something 5 or 10 minutes that they could play repeatedly or do it live once and then make it available for their staff whenever their staff are available to watch it.
Terrific. Thank you. The next question I'm going to direct to Anna about your survey to RCFE residents. How many were veterans or did they have access to telehealth because they were a veteran or they had Kaiser? And it's a kind of a two-part question I'll add in here is, how do we get more older adults to have smartphones, internet access, know how to use, the technology to be able to do telehealth?
Yeah, that was such a good question, and I wish we had done a better job of assessing that. In fact, we've been reached out to by wonderful colleagues and other health plans and programs that wanted to collaborate more because they have a lot of patients in these facilities. And we just did not assess that in our initial survey, but we're going back in our outreach and trying to do a better job of knowing how to liaise with various health plans or health programs that really do more wraparound for their folks. And we actually didn't assess the telehealth aspect either. But it's through some of the caregiving services, like in-home supportive services. I know they're working on help establishing that because they want to be able to help their clients connect to care better. So I think the RCFE folks are great candidates for if there is a device, because they're more likely to have somebody to hopefully assist them, particularly if they're struggling with any sort of cognitive or vision impairment. But it's a great question. I think devices that are more user-friendly is certainly one solution, and that hopefully will get more broadly adopted. Like I know Carla has done a lot of work with grandpads and things like that. But any suggestions for how to improve access to actual technology and digital literacy, I welcome and would love to learn more about too. Thank you.
To jump in to add that we can learn from the higher end facilities where, there tend to be three categories of older adults: those that have devices and can use them, those that have them courtesy of their families usually and don't use them, and those that can't afford them and, don't have them. And so the first group doesn't need help. The second group, the staff at higher end facilities, which are better staffed, helped them get on. And then at the higher end facilities, the people in the third category, also they bought communal devices, and people would make appointments with the staff, and the staff would help them get on and speak to their families. But this was sort of compounding disparities along racial and economic lines.
Great. And maybe I'll throw a question to Carla about, has anyone talked to folks who are doing well coping with shelter in place? There may be a lot to learn from those who are doing well, sort of the disease wellness dichotomy.
Yeah, so two things. And before I answer that, the question about technology, we are actually piloting the use of age-friendly devices in a couple different settings. One, in adult day health centers, which, as you know, are currently closed, so seeing if they can be used to bridge the gap between adult day health and people being at home, using it in some of our community clinics that don't otherwise have telehealth right now, and because of the fear of older adults coming to clinic. And I think what Dr. Aronson mentioned about learning from some of our other facilities is something we've done as well. So what we've done in our geriatrics practices is really get an understanding of where our patients live, which is no small feat, and actually an ongoing process to have a field in our EMR, which demonstrates if someone lives in a group setting. So we actually can help understand risk as people return to healthcare, and designating a person that we can contact to facilitate. That is more for medical reasons and doesn't get at the social reasons. In terms of people doing well, I think there's two parts of this. So one, in our homebound population and many of our patients who are already homebound and quote unquote isolated, they haven't seen that much change to their lives. And so they're actually doing just fine. It's more of the people where they're used to having something and they're suddenly in absence. Some of the ideas that Dr. Kotwal and I are exploring are this idea of resilience and positivity that we hope to learn more. Unfortunately, the reality is we will have COVID pandemic round 2 and shelter in place round 2, and preparing for that so we can understand more.
Great. And Eric, there's a question here about this could be many of the panelists could probably answer some of this, but many of the long-term care facilities are interpreting end-of-life care allowance for visitors to facilities as being actively dying only. However, obviously, that's not the best part. Like, do you have thoughts on that, or how could we advocate so that we allow, a more uniform approach to having visitors, whether that's supporting PPE, training for facilities, that this is an important part of patient care?
Yeah, I feel like this is an ongoing, you have to balance both the needs of the person in the facilities with what's going on around it. So especially early on when we didn't have enough PPE in the hospitals, let alone nursing facilities, visitor policies needed to be strict to protect everybody, including not just the patient that's in front of you, but everybody around and the nursing staff, and also saving some of the much needed PPE that we had. As facilities have more PPE and could accommodate more visitors, I think our visitor policies should also potentially expand, with the recognition that like having 15 people visit probably at this point in many places is still not an optimal thing to have. So maybe limiting the number of visitors, but also as we start opening up our society and our economy, I think opening up our visitor policies is important too. It's actually something we just talked about today with the ICU team here at the San Francisco VA. So I think it's important.
Terrific. We're at the top of the hour, but I thought I'd give one more, have everybody just say one brief thing about how families can support patient mental health for, you know, whatever setting people are in, any one tip that each of the panelists might have to give to families about how they can support older folks during this pandemic. And I'll start with in order of how you presented. Ashwin, I'm sorry, Carla. Carla, you went first.
Yeah, so I would say the one thing is to not make assumptions about what older adults want and actually first ask them.
I think being proactive, you know, making that phone call and reaching out, being the first one to reach out is always a good step.
Oh, they took the two best ones. I guess think of how you can be helpful in giving purpose and meaning to a person's day in what a life that is already a little constricted and just got much worse.
I'm going to be less existential and a little more practical. Like if somebody is in a facility or somewhere where there's, you know, more of a congregate setting, reaching out to the administrator and asking how you can help with things that they're probably already working on to try to increase socialization and support.
I'm going to say ditto, but also I think that Louise's point, sometimes when people are feeling lonely, just reaching out or actually asking them what they need, or asking them, sometimes people want to help other people, and that actually makes them feel good. So thinking about ways to connect other people to help and support each other.
Think about 5 people who you think may be at need or at risk with this pandemic and the social distancing that we have. Just give them a call and see how they're doing.